Good afternoon, everyone. Thank you for the warm welcome. So let me start with a question for you. If you have $1 and you really like oranges, would you buy 1 orange or 4 oranges? Great, you're good. So that was not a tricky question. Now, if you want to invest in a program to improve the health of children, and you're trying to decide what program to invest in, the answer is actually not so obvious. Right? So what this graph does is that it compares the cost effectiveness of, or in other words, the returns on investment of 3 programs that aim to reduce the incidence of diarrhea for children. So one is the program that consists in encasing water sources in concrete so that the water comes clean. The second program is the hand washing campaigns. And the third program consists in putting chlorine dispensers right next to the water source. So as you can see, there is a big difference, right? With the program on the left, you can avoid 500 incidents with $1,000 and less than 100 with the program on the right. And I bet that if I ask you to guess which program corresponds to which column, not everybody in the room may have the same answer. So it turns out that the most cost-effective program, they're actually all quite effective. The most cost-effective among the 3 is the chlorine dispensers program. So this program actually increased the usage of chlorine by households 6-fold. The reason is that it's a very convenient and salient solution. It's right there next to the source, so it makes it easy for people to remember when they come and fetch the water that let me put chlorine. The same way that we don't have to think about chlorine in the morning, it's already in our water. It's also a pretty cheap solution because it's at the community water source. Anyway, the point of this graph is really twofold. One is that there can be a big difference in the impact that you get for your dollar. And the second is that the answer about which one is most cost effective is not always obvious unless you have good and precise measures of impact and cost, of course. Actually, based on this research, this program is now being scaled up by an organization called Evidence Action throughout Kenya and other countries. So this is why Innovations for Poverty Action, my organization, was created 10 years ago by Dean Carlan, who is a professor here at Yale. So I'm going to very briefly describe our approach and then give you two examples of how we measure and then use impact of development programs. So our approach is very simple. In partnership with implementing organizations, we identify problems. So high incidence of diarrhea or people don't clean their water. Then we figure out what solutions could potentially address those problems. And then we evaluate the impact of these potential solutions using rigorous evaluation methods. We mostly use the randomized control trial methodology, which is the same methodology that's used in the medical field to evaluate the impact of medicines. Once we have understood which solutions are most effective and most cost-effective, we then mobilize implementing organizations, whether it's governments, non-profits, or funding agencies, to use the most effective solutions in their programs, ultimately to improve resource allocations in the development field. So we work in partnership with more than 100 academics from various universities, including Yale, but others as well, and as I said, in partnership with implementing organizations, non-profits, governments, and for-profits as well to do this. We work across sectors, including the health sector. And most of the questions that we try to address in the health sector revolve around this problem, which is that there are a lot of things that we know work. We know that vaccines can save lives. We know that safe water is better than unsafe water. We know that insecticide-treated bed nets can save lives by protecting people against malaria. Now, a lot of people actually don't use these things that we know work. So we call this the last mile problem. So a lot of the questions we try to answer revolve around this, and there are potential reasons for that, both on the supply side. So maybe it's an access problem, maybe it's a problem of corruption in the health system, or it could also be on the demand side. Maybe people don't know that these solutions are good. Maybe they don't care. So let me give you one example on both the supply and the demand side. So starting with the supply side. In Zambia, where we have an office, like in many other countries, the ratio of doctors to the population is really low. So a lot of organizations, whether it's non-profits or governments, try to use community-based workers to complement the low supply of health providers. Now, a key question that these organizations ask is, how can we, often these health workers are volunteers. So there is always this question of how can we use these volunteers in the most effective way possible? How can we make sure that they're really going to do their job because we don't pay them? So we worked with researchers from Harvard and an organization called PSI, Population Services International, and their partner in Zambia to address this question. So what this organization does is that they use, that's one of their programs, they use hairdressers and barbers in the city of Lusaka to distribute female condoms. So women go a lot to these hairdressers, they trust these people, they start chatting, so the idea is to use these hairdressers to distribute these condoms. So the question was, how can we incentivize these hair workers, these hairdressers, so that they distribute as many female condoms as possible? So one potential answer is to motivate them by giving them financial incentives. Now, some people say financial incentives are not the most effective. Maybe there are other ways to motivate people that would be cheaper and more effective. So we said, fine, we can answer this question and test both. So the researchers set up a randomized control trial. They first identified 1,200 hairdressers in Lusaka. Then they randomly allocated these hairdressers to 4 groups. The first group received a small financial incentive, so they would get 50 kwacha per pack sold. The second group received a higher financial incentive. The third group didn't get any money in addition to what they normally get. They would get a social incentive. So for every pack sold, they would get a little star, and would be a poster sort of tracking their progress. And it was all made very public so that people could see that they're really doing well and doing a service. And the fourth group is the comparison group. So it was the pure volunteer group. So there was nothing was changed there. And so what did they find? Well, they found that the social incentive or the status incentive was the most effective. So they actually sold like twice as many packs as those hairdressers who received a financial incentive. And the financial incentive was actually just a little bit more effective than the pure volunteer group. So this is one example on the supply side. How can you make a community of health workers even more effective by providing them incentives? We are now doing similar studies with rural community health workers, which is a more traditional way to use community workers than the hairdressers. Now, another example on the demand side. So the setting here is Rajasthan in India. This is a state where immunization rates are really low. So we know that vaccines can save lives. In the last 10 years, there's been a lot of progress in the rate of immunizations, but there are still a lot of pockets where immunizations are really low. At the time of the baseline survey, a couple of years ago, the rate was 2%. So 2% of kids had received the cycle of 5 vaccines that's recommended by the WHO. So this is actually in a context where vaccinations are free. So why don't they get vaccinated? Is this because even though there are health centers in these villages, the nurses actually are only there 50% of the time, which we know is a problem? Is it because parents don't know that vaccines are important? Is it because they know but they procrastinate like we all do? Like we in this room, we don't even have to think about vaccinating our children. It just happens, right? So again, researchers from MIT, in partnership with a non-profit called Seva set up a randomized control trial to answer these very questions. So 134 villages were selected in the state of Rajasthan and then randomly allocated to 3 groups. The first group is a health camp. So a monthly health camp was organized by the non-profit Seva Mandir in those villages. So the idea is that once a month there was a supply of vaccination which was very reliable. The nurses would be there. And with this health camp, the nurses would also educate parents about the benefits of vaccination. So there was a bit of education as well. The second group, the same health camps would be organized in those villages, but in addition to that, parents would receive an incentive for every round of vaccination. So you're supposed to go 5 times. They would receive 1 kilo of lentils every time they go. And once they have finished the full cycle of immunization, they would get a plate. So this is an incentive which is actually very low. It's actually a little bit less than a day wage. Right? And the third group was the comparison group. So none of this would happen. So one thing I didn't mention before, just so you know, the benefits of doing randomized control trials. It's not always possible to do them, but when you can do them, it's a really good way to evaluate the impact of social programs because it isolates the effect of the program from other factors, like the intrinsic characteristics of beneficiaries, like motivation, for example. It isolates the impact of the program from the passage of time as well. Right? So anyway, what did they find? They found that both immunization camps and the camps plus the incentives were quite effective at increasing immunization rates. So if you look at the immunization camps, the rate rose to 17% of children who completed the cycle compared to 6% in the comparison group. So it really helped. But what happened with the immunization camps is that people would go to the first round and then maybe the second one and then they would stop coming. Whereas with the incentives, they would actually continue to come and they were more likely to finish the cycle. So with the incentive treatment, 38% of kids were immunized compared to 6% in the control group. And because there were more people coming to these camps, this program was actually also much more cost-effective because the cost per minute of camp went down. Anyway, so these are two examples. In terms of conclusion, another thing that I'd like to mention is that it's one thing to do this experiment to understand what works and what doesn't. It is really important. But what's really important also is to ensure that these solutions that are demonstrated to be effective are used and applied by decision makers, people who implement, design, or fund programs. So, for example, in those cases, what we're doing is that we're working with those organizations that we worked with to evaluate the impact of these programs. We are helping them raising funds, for example, to scale those programs. We are also working with other decision makers to communicate these results to them and help them understand how this could apply to their work. So, for example, we're working with the Ministry of Health in Zambia to evaluate similar ideas with their community health workers program through that. One is that, as I mentioned, there is a last mile problem. In the health sector, a lot of solutions have been developed that we know can save lives, but often they are not used. So lots of hanging fruits, but they are not being picked. It's really critical to build rigorous evidence about what can work to get people to use these solutions. And it's really important to use the most rigorous methods to do so, randomized control trials or other methods as well when that's not possible. So third thing is that, going back to the last mile problem, so it can be, it's really a problem of customers not using those solutions. And very often the answer revolves around, it must be a supply problem, or maybe it's because people don't know, are not aware. But as we saw with the incentive program, it's not just a question of supply, although it is to some extent. It's also not just a question of building awareness. Also, it might be to some extent a problem. But there are issues that are more behavioral that relate to procrastination, for example, or just things not being salient in your mind. So as I said earlier, every morning your water comes chlorinated. You don't have to think about it. You don't have to think about getting health insurance or vaccinating your children. All of these things are taken care of for us, and that's not the case for most poor people. So that leads me to the last point, is that it is often the case that very simple interventions, like very simple nudges, can really go a long way in getting people to behave in a more optimal way. But there can be other types of very simple solutions, like, as I mentioned, status incentives to encourage health workers to be even more efficient. So that's what I would like to leave you with today, and I'm happy to answer any questions later. Thank you.